would do with that is that you would negotiate the meal with them. So you can choose one. It's better to negotiate, because if you say with breakfast, they don't eat breakfast, then it won't get done. The other is the Cialis. So I'd like to hear from Kristen what she's seen in her practice, at least from Medicaid. When I was practicing, they would only pay for 10. And that was usually considered a month's supplies. The other is that they'll sell them, or at least the population I dealt with would sell them. So, pardon? Yep.
It's like 10 to 12.
So usually we gave them 10 as a month supply, and I would just give them 11 refills on that.
Or we had a guy, I swear he was a pimp, came in, got Viagra, he was like in his 40s. Every month. I swear he sold them. Yeah.
So did you all ever have insurance kick them back if they did more?
Yes, we had one guy, I guess you can use Cialis for blood pressure. Like
I've not seen that.
But we had a doctor try to do that, and the insurance bought them the entire time. So
a couple of things they could have been doing. One is that if you don't want if you don't have a couple of ways. One is that you get it under a different indication, then they might think they can get more. The other would be they don't want that indication on their medical records.
Yeah. But yeah, the insurance bought the entire time. We could only, I think I've seen the max is 12.
Okay, I think Medicaid was 10 but that was a few years ago. Any other questions about the prescriptions due tomorrow as is your redos? Any question on the redos? Did you like those charts?
Yes.
I like them because they're fast for me. So I'm going to keep using them unless you all have a different idea. Better, different idea. Any questions from yesterday? Or yesterday, 2 days ago? Anything over acute kidney disease or chronic? We're going to pick up with the vitamin D as I had where I left off.
They couldn't get anywhere, so I slipped in the mud.
Oh gosh. Okay, well, go clean up.
But I brought cookies for my grandpa.
Did anybody hear anything over the noon hour about how much rain? I did, on my little pop-up, it said that between Bethany and the village, they got about 3 inches.
I saw a car float through an intersection on the way here.
Say it
I
again?
saw a car float through an intersection on the way here.
You did?
Where?
Which intersection?
122nd Santa Fe.
Which, Santa Fe and what?
122nd.
Oh, really? That far north?
It was bad in Edmond.
It was bad and terrible. Like the hail on the way here. Pull over 80 mile an hour straight winds, easy.
Wow, Morgan's
And,
really flooded.
The fire
Yeah,
truck
that's
came and shut that
what-
intersection down right after I got through it. So,
Oh, really?
yeah,
Wow.
I was like, I gotta get there. For my
How did
plate.
you get around it?
I cut the corner like big time.
Yeah.
And they were a tiny little Corolla, like probably 90s Corolla. So as the SUVs were making it through, so I was like, all right, I'm going. But,
Wow, Kristen.
My husband's been stuck on 235 for almost 3 hours now.
Wow.
Because the river's over it.
They, yeah, they cut it. This
Which part?
He's going northbound, I don't know where
it's
Down
closed
in
down.
the river, so.
The river right before downtown? Like the Oklahoma River, like.
No.
No, I've
So, but on 235, so 235 starts at about
It starts
at
after
40.
Yeah.
It's closed from 40 to 36th Street.
Say it
It's
again.
closed from 40 to 36th Street right now.
Oh, really? Wow. Wow, I'm trying to think of where the river goes.
definitely
There's
not
a
at
ditch, there's a drainage ditch that's maybe.
Just
Wow. Were y'all around when, probably 7 or 8 years ago, we had a huge flood. I mean, like on I-40, under those underpasses, it was like impassable 6 to 8 feet. Right, any of y'all around or
I was
not?
going down to Texas when we got all that rain and the Red River flooded, and they were there was 4 cops on each side of the river ready to close it down whenever it pressed over the interstate.
That's a lot of rain.
It never did. It was like 2 inches like right under the road. It never pressed over, but that was 5 years ago.
Wow.
It was crazy. We got all that rain.
Impressive. Okay. All right, then let's pick up with vitamin D. So you know it's a fat-soluble vitamin. You can get it through your diet, but there's not a lot of foods with vitamin D. We get a lot of it through sun exposure. But with the last decade or so, people being worried about increase in skin cancer, people covering up more, using high-powered sunscreens, then people are more at risk. So it takes about, for a very Paul in the sun for 15 minutes.
That's more than enough time.
He could get all the vitamin D he needs. The darker the skin, the longer it takes. So your darkest blacks could take up to an hour or more. So you have to counsel people if they want to get their vitamin D through the sun. Then the fairer you are, doesn't take long, the darker your skin, the more melanocytes you have to protect your skin, then the longer it will take. So it can take an hour or more. Okay, so we can get D2 and D3 through sun, through or diets or supplements that we take. The liver converts that. This is the important part. So the liver converts those to calcidiol. So 25-hydroxy vitamin D is what you can measure. That will tell you if the liver can handle that. The kidneys also come into play, so you have to have both organs operating. So the kidneys will then convert it into calcitriol, and then that effect is on intestinal absorption of calcium. So you got to have adequate vitamin D in order to get the calcium out of the gut. Bone resorption and decreases calcium and phosphate excretion by the kidneys. So you can see when the kidneys are not working well, which since we're talking about chronic kidney disease, then you may have to supplement. So you're going to have to monitor their vitamin D levels because that will also help regulate their calcium levels as well. So you may have to supplement these folks. And, whoops. So the way you supplement, if you look on the next page, is ergocalciferol. You're going to check the liver's ability to produce the 25-hydroxy, and then if it's low. Now, this kind of is a moving target, but it's considered low if it's less than 30 nanograms per milliliter. So you can see it's very small amounts. Nanograms are really low, small amounts. Okay. When you start, if you do supplement, you're going to have to check calcium and phosphorus also, because these will change those absorption and excretion. When total calcium gets to above 10, then you're going to have to stop therapy. So 10 is like the lower end of normal range. Okay. So keep in mind that flow. What do you check? What do you supplement with? What are your endpoints? One is, really we're going after calcium here, but we're using vitamin D because they can get deficient in their ability to produce an active form of vitamin D. There is another drug on the market called Sensipar, and it is a calcimimetic. It actually works differently. It's not supplementing them. It is changing the ability of the parathyroid hormone to react to serum calcium levels or phosphorus levels. So it's indicated in secondary hyperparathyroidism for patients. And I think Dr. McNeil told me he talked to you all about this. So in chronic kidney disease, that parathyroid hormone goes up, and that's what causes a lot of the osteodystrophies, is because they reabsorb a lot of the calcium out of their bone unless you do something to stop that. Okay. Questions about vitamin D you need to supplement? Yeah.
So with the supplementation, if you have a liver issue like hepatitis or a kidney issue, would you still have problems converting the supplement?
Yes, you might.
Okay.
Liver has huge capacity.
Okay.
So you have to have pretty severe and limited cirrhotic disease in order to do that.
Okay. But with kidney issues, would you just have to give a higher dose then of vitamin D? or, I mean, are you gonna have like trouble converting it from like to the 125 hydroxy?
Yes.
Okay.
Because usually when we're talking about chronic kidney disease, well, if you're dealing with like stage 3, even stage 4, they're gonna have enough capacity to do this. Mostly you're gonna have trouble in stage 5. You can have it with stage 4. You'll see varying degrees once you hit below 60 mils per minute, then you're getting into stage 3. So it's a progressive continuum.
Okay.
I have a question.
Yes.
There was a lot of people on vitamin D2. What would be the indications for a D2 versus just over-the-counter D3?
Well,
Nothing? Okay, because I know like the D2 was like once weekly. Is it just preferred once?
well, you can do it once a week in big doses, since
Yeah.
it's fat soluble, you can do that. And that's usually when you're trying to replace stores. Then we put them on a daily amount, small amount, when this is getting beyond what, this is vitamin D replacement or supplementation to correct a low. Most people are low these days because we don't get out in the sun and we use sunscreens. So when we get to osteoporosis and think, we'll talk about it more. And so what you're talking about is going more towards people who have, they have a low. So it's now kind of one of those in vogue things to monitor is vitamin D, and nobody really knows exactly what is the right amount. It has been linked to, low vitamin D has been linked to multitude of diseases. Diabetes is one that they've been looking at. So they've been raising up. We don't think there's any high end. It isn't like vitamin A where you can have neurotoxicity due to too much. So vitamin D doesn't seem to have an upper limit. Some people push the serum levels up to 100, and we're talking about less than 30. So most of the time people will try to get them in about the 40 to 50 range. That is replacement or supplementation from what is perceived to be a low. But nobody knows exactly what that is and what the ramifications are.
Okay.
But it's something, so what you're seeing is actually probably not kidney disease.
Yeah, it was little old ladies.
Yes, see, they're usually osteoporosis, so they're doing that
I was just wondering.
to help maintain bone health.
Yeah.
Okay. Good questions. Okay, page 25, so adjusting doses in chronic kidney disease. So there is the recommendation, at least from the National Kidney Foundation. They put out very good guidelines about the treatment, and everything to do with kidney disease comes out of that National Kidney Foundation. You do not have to memorize those, but kind of get a sense for that. The one I'd really get a sense for is that 30 to 59, because when people start getting down there, you're in stage 3. So that's where you often will start to see that you will have to modify dosing of drugs. Not all drugs, but a lot of drugs that you're going to be using in elderly. So your older diabetic patients, I can guarantee you that's where they live, in that 30 to 60. People can still do well when they're even at stage 4. Their serum creatinine is going to be higher. You'll note that stage 3 you would see a higher serum creatinine. And with the fact that you've got a disease that has high risk, so severe blood pressure hasn't been controlled, diabetes, 2 common ones you're going to see in practice that are going to be associated with chronic renal insufficiency. So people may use that term instead of chronic kidney disease. So renal insufficiency, chronic kidney disease, kind of 2 different ways to describe. Usually if people have, if they're going to be dialysis or they're ultimately have to go to dialysis, they may talk about an end-stage renal disease, renal failure. So all those terms have similar meanings. They may be applied to varying degrees of renal disease, so it gets confusing. But those are all meant to describe a situation where the kidneys are not able to excrete all the toxins and loads that they are presented, and drugs then fall into that. Because a lot of our drugs are, remember, we have changes by the liver to modify drugs to make them more polar. Remember? We talked about it in the very first module. So we have those phase 1 and phase 2 different types of metabolism. So the liver takes a drug and makes it more soluble for the kidneys to get rid of. So it usually involves increasing water solubility. So that's why we add these polar agents, so that they're attracted to water and the kidneys can get rid of them. So active metabolites or active drugs that are excreted by the kidneys are the ones that are going to be most effective. So creatinine clearance can be a good reflection of their filtration rate. So if you look on page 26, this is Xarelto. I mentioned this when we talked about drugs for prevent clotting, AFib. We used, our brain is just zipped. So anyway. So, I keep thinking antiarrhythmic. Okay, like warfarin, drugs that are going to decrease clotting, anticoagulants. Okay, so an anticoagulant that is dependent on renal excretion. So if you look on the page 26, this is what would be in the drug monograph. So if you were to go onto the website for this drug, in the monograph, it will always give you this data. It's required by the FDA. So this is the way it would look. This is the way it looks for Xarelto. They often lay it out like this. Or they may just state no modification needed in renal insufficiency or renal failure. You'll also, if you use Lexicomp, if you use Hippocrates, it will do the same thing. Those are going to reflect what's in this monograph. They are not going to alter off of what is in here, because that's what the FDA has approved for them. So they can't change that data. They can't promote a different dosing. That's what I'm trying to get across. So if you look at Hippocrates, if you use it, you might just pull up Xarelto at some point and look at this. So dose and administration. So here for Xarelto, it depends on the indication. You often don't see that. This is a little bit more unusual. So it's telling you for the indication, if their creatinine clearance is thus, here's how you dose them. Okay. Most of the time, we don't modify that many drugs that when creatinine clearance is above 50 to 60. But I'm telling you, at about 60, you'll start to see some drugs will need to be adjusted. So you see here, creatinine clearance 15 to 50, we move it down from 20 once a day to 15 once a day. All right. You look on page 27. Usually if we're going to load a patient with a drug, so usually antibiotics is what we've talked about. Loading goes more to distribution. Loading goes more to filling up all the space that a drug is going to move into. Usually isn't affected by excretion or metabolism, so we usually don't modify a loading dose based on clearance. Clearance is going to affect more your maintaining or continuing dosing. Some ways that you can adjust that. So I'll give you some examples. So vancomycin, we've talked about it. It's renally eliminated. And we talked on Tuesday about the fact that those trough levels are related to toxicity. Well, let's say we have a trough that comes back too high. We can do two things. We can decrease the dose, or we can extend the interval. So instead of dosing it every 12 hours, we could dose it every 24. Because our goal is to get that trough below a certain range. Okay, so here we're at steady state. Let's say we're dosing that drug every 12 hours. But it's above where we want it to be. So if we move it to Q24, then what we get, I can play this now. Okay, you can do this. Okay. See what happened? We extended it out, it gave it longer time for it to fall, or the body could then catch up and the clearance became more significant and impactful, and those troughs came down here. So antibiotics, that's one of the ways we do it when people have renal clearance issues. And commonly they will in the hospital because they're sick. So their kidneys are not always working. So aminoglycosides we would do this with. Vancomycin we would do this with. So we can extend the interval or we can drop the dose. So that's one way. Okay, some other examples of what happens when renal clearance isn't normal. Thiazides. Thiazides don't work very well once you get below a creatinine clearance of 30. Okay? Because at that point you can't deliver enough sodium to the distal tubules to make the drug effective, for the drug to be effective. So that's a physiologic change in an organ that where the drug works now, there's not enough for it to work on. So that's an example. Some beta blockers, down to the third bullet. So some beta blockers are hydrophilic, meaning they're water soluble. Some are fat soluble. Propranolol is fat soluble. We don't care about the kidney or fit. Elimination doesn't depend on that so much. But some drugs, some of the beta blockers like atenolol and nadolol are water soluble. So you have to pay attention to those so that you can modify the dose in renal insufficiency. Metformin, another drug that is contraindicated and should be avoided when creatinine clearance is less than 30. The reason for it is that the toxicities go up because we can't clear the drug as fast, and so it can accumulate, cause lactic acidosis, lactic acid to accumulate, increases the risk of a side effect. Glyburide, which is another drug to treat diabetes, has an active metabolite. So if you don't change the dose, then what happens is you put them at risk for having greater risk of lows. So what I'm doing is going through and showing you what happens in different aspects of renal function and effects of drugs. Aminoglycosides, I've already showed you up there. Nitrofurantoin, which we're going to talk about today, is an antibiotic. If you can't it is a good drug for UTIs because it concentrates in the bladder. If you can't filter it into the urine, you can't get it to the site of action. So that's another reason why we don't use it when creatinine clearance gets below 30. Meperidine or Demerol. It has metabolites that will accumulate and can cause a lot of neurologic. People can have really weird hallucinations with it, or respiratory depression. We have to decrease the dose of morphine in renal failure. And non-steroidals can provoke it. Okay? So see why I am so adamant about, know what the renal function is. But you will see out there that providers don't pay much attention to it. Okay, so let's look at some problems. Page 28. Here you have a 68-year-old African-American female with diabetes. Her most recent serum creatinine is 1.6. She weighs 188 pounds. Her healthcare provider wants to start her on Januvia. The dosing of Januvia is listed below. So based on her renal function, what dose should you choose? Okay. So calculate her creatinine clearance if you haven't done it already. Somebody give me the equation.
40 times kg.
Over 72 times
Okay, weight has to be converted into kilograms. Okay.
Times 0.85.
And for this, 0.85 because she's female. Okay. So what did you get?
45.
45?
Yes.
Everybody get 45? Anybody have trouble getting that number? So if you look this up on Hippocrates, what would you say her dose needs to be?
50 milligrams once a day.
So it's 100 milligrams once a day is the usual dosing. Because her creatinine clearance falls between 30 and 50, then her dose should be reduced to 50 a day. Everybody get that? Anybody have questions on it? Okay, let's look at the next one. 72-year-old, 90-kilogram Caucasian male with peripheral neuropathy is taking 600 milligrams 3 times a day of the gabapentin. He complains of dizziness and sleepiness. Recent creatinine is 2.3. Based on the dosing recommendations that are in the monograph for, did I not put the drug? Gabapentin. What dosing adjustments should we make? You will have to do this on the test for in some regard, so. Okay, so what'd you get? 37 mils per minute, okay. Sometimes you ought to step back and say, does that look right? For somebody who has a creatinine clearance of 2.3, that's about the right. So you should start to get used to that or accustomed to what would their renal function or should their renal function look like. Okay, so based on that,
We had nothing done with the guy.
right, so it gives you a total dose range, but in this case, it gives you different ways to give it. So BID or TID, TID you're not going to do, but BID, different dosage range would hit that 400 to 1400. You encounter that on your prescriptions, right? With the Cipro, you had a range. Okay. I would say the closer you are to the end of that range, the lower the dose you ought to go, because the longer the drug's going to hang around. Everybody get that? Yes.
For a drug like that with a range of, 1,000 milligrams difference, would you normally maybe start the patient on the low end since that's so variable? Or it is?
Depending, for me, it would be more depending on pain. I'd probably start them on 300 twice a day because it's an easy dosage for them to get and start them. It wouldn't matter.
Do you think going from 600 3 times a day to 300 twice a day?
Yeah.
Yeah. You want to just do like
Based on
600
his side effects, yes. But because the 1400, it really is not enough of a change, I think. Also depend on how well he was regulated, pain was responding, and he's an older man. So the big thing there is to follow up once you have made a change. Okay, everybody see how to use those? Yeah. So now when you look on Hippocrates, you'll be able to make dosage adjustments for your patients based on the renal. All right. Let's start with the urinary incontinence. It's just smaller, shorter. Have you had your ClinMed on? Okay, so tell me what you learned.
There's several different types.
Yes.
Some are not true.
Okay.
Yes.
Stress, what are you saying about stress incontinence?
So the two most common are urge and stress. Urge is the one where your brain miscommunicates that you have to pee. And then stress is where you're doing something and you can't, like the sphincter tone can't actually retain your.
Yeah, that's close. Good, what else? Say it again. That's why it's very frequent in women. Which one?
Stress.
Stress, yeah. What else?
When you say look at urodynamics, that's for
You can.
something about heat.
Or what is it, you can have like a stress or like a bear down,
Yeah.
a bear down test to see if they.
Pee. Yeah.
Take the
Urge with the anti-spasmodic medication?
Antimuscarinics, maybe.
I think she called them spasmodics, but
Okay.
whatever the name.
What was she, spasm of what? What are we trying to keep
Is
out?
the actual sphincter itself?
No.
Or is it
Anything else? Luckily, there are not a lot of drugs for either one of these things we're going to talk about today. So that's, and some of them you've heard of before, so that's good. Okay. So in terms of urinary incontinence, very common in women, very common. In fact, as I was going through the handout this morning, I'm like, I did this whole thing for women. So I will give you some male statistics. So it can happen in men, it's just very less common, and it happens to everybody with age. So with men, as you get to in the 60s and 70s, the percent lists are very wide, anywhere from 10 to 30%. So you can see for women at older age in those categories, it's about 75% of women, men it's about a 30%. So a little bit less. With men, it's mostly prostate is the major risk, diabetes and neurologic disease. So you see with women, it's even common in young women, 25%. 50% of middle-aged and postmenopausal women. 75% of elderly women. Most women are not going to seek help. And it can have a significant impact on quality of life. You've seen the little Mermetric commercial where the bladder is dragging the woman into every bathroom they go by. That's what they're trying to get across, is the quality of life issue. So risk factors: pregnancy, vaginal births, weaken those pelvic muscles, and so the stress incontinence becomes more common. Loss of estrogen after menopause is a common cause. And did you all talk about using estrogens to in some types of incontinence? Okay, we'll talk about that. Obesity. So just the pressure of the weight of the abdominal fat on the bladder can also cause. So recommending weight loss in the obese may be helpful. Urinary tract infections or chronic inflammation also can set up like an urge incontinence. Functional cognitive impairment. So this one is odd. So is it a neurologic part of the disease, or is the disease that they can't recognize when to go to the bathroom? So that sometimes is a hard one to tease out. Chronic cough. So it's really cruel to put them on an ACE inhibitor and not pay attention to that cough in some of these types of incontinence. Constipation, so that bearing down can also then lead to incontinence, is what they're getting to. So mechanisms of urinary incontinence. This is fairly common in men, probably one of the more common ones in men. And men that have incontinence tend to be institutionalized more often than women. So men it goes more to a more neurologic diseases, advanced diseases with them is what they're getting across. Also, men tend to suffer more from depression if they have incontinence. So pay attention to the men and keep those kind of comorbidities in mind. So spasms of the bladder can be due from lots of reasons: nerve, muscle damage, infection, inflammation. patient may describe it as an urgent need to pee, not to pin, and they can't get to the bathroom in time. So keep that woman running in mind when you're thinking about it. Sound of running water, sound of somebody else peeing or urinating may also set off their urge to go to the bathroom. For these women, they may have complaint of a lot of urine leakage, so they may use pads. So asking them about that may also help start the conversation. Stress incontinence. For men, prostate surgery is the most common cause of this. So either a radical prostatectomy or a TURP, transurethral resection of the prostate, is a common cause of this in men. Very common in younger women. You can see it's a loss of muscle strength. So that sphincter, so there's two sphincters, right? And so the internal, external sphincter either don't close or when a weight or pressure is applied, and so they leak urine. So you can see all the reasons there: weight gain, sports injuries, pregnancies, vaginal deliveries, which you all have already mentioned. Mixed incontinence, probably the most common in women, very rare in men to have that. And then overactive bladder. These women usually aren't incontinent. Maybe that's what they meant by not a true incontinence. So not everyone will complain, but they'll complain more of just frequently having to go to the bathroom. So more impact on life. I had a patient one time who worked for Walmart, and she had this problem, and they got tired of her having to go to the bathroom all the time. Now this is her story back to us. And so what they did is to kind of encourage her to leave work, move on, is they kept moving her further and further away from the bathroom. So she said, every day I would come in, I was in the register furthest from the bathroom. So it had a big impact on her. Okay, so non-surgical treatment recommendations in women. Did you all talk about pelvic floor training? Okay. So for this condition, the recommendation is more lifestyle. Drugs are further down the road. And as when we talk about them, I think it'll become apparent why the side effects usually are very difficult for people to deal with. Plus, they are just not that effective. Their effects are mild. So they really shouldn't, or they're not that significant. So keep that in mind when thinking about using drugs for them. Okay. Oops. So look at the picture on the next page. I'm going to switch. Okay, so lots of innervation of the bladder. You've got parasympathetics that are innervating the muscle. You have two sphincters. You have the internal and the external, and those are primarily sympathetic innervation. So I gave you a chart on the middle of page 3, looking at two major jobs that the bladder has. One is to store urine, and one is to get rid of it. So depending on what the bladder is trying to do is whether the parasympathetics or the sympathetics will be engaged. So in urine storage, we want to inhibit that muscle, right? So the parasympathetics are inhibited. And your sympathetics are firing because they're keeping those sphincter toned high so that you don't spill urine or leak urine or urinate while the bladder is filling. And then when urination takes place, then that's the parasympathetic effect, and the sympathetics are inhibited. So remember what I told you about SLUD and anti-SLUD? Okay, so you should use that to remember this. So what was SLUD? That's why I put it wrong. All right, so this is what the cholinergic system does, right? Cholinergic, the neurotransmitter is what? Acetylcholine. The receptors are referred to as what? Muscarinic. So if your parasympathetics are working, then your urination is going to be the predominant. Then when we use anti-SLUD, then that's what we're going to use those drugs for, is to decrease urination. So we're going to affect mostly the effects on those bladder muscles. Okay. So let's stay with urge incontinence. That's where most of the drug have been approved. So symptom-wise, here with urge, it's the frequency, urgency, high volume incontinence, nocturia. So these women, or men, will use pads at night. Now women that have other types of incontinence usually don't use pads during the night, but these women will, or men as well. So what's our goal? Well, we want to reduce the number of times they have to urinate through the day. We want to increase the amount of urine they can store before they have to urinate. And we want to improve the quality of life. So in terms of pharmacotherapy for urge incontinence, we can use the antimuscarinics or anticholinergics, but they're referred to usually as antimuscarinics. And these are, but they're not, it says first line, they're first line of drugs, they're about the only drugs, but they're not the first line therapy, right? So first line therapy is going to be those other things you all talked about, lifestyle. So what kinds of things would you talk to the woman about doing differently? Losing weight, Kegel exercises, strengthen the pelvic floor, what else? Schedule, tell me more about that.
I think she said she'll tell her patients, just make yourself go every 2 hours.
Right, so
before you, like, eat your body needs to be.
exactly, yes. So toilet training is important. So it gets the body very used to that. That's a very good. What else? What did you tell them about diet? What irritates the bladder? Foods or things that irritate the bladder? Caffeine's probably one of the big ones. Probably the least adhered to. So not so much salt, but looking at bladder irritants. So in terms of the anticholinergics, there, if you look on page 8 and 9, I have made a 2-page chart of them. They come in first generation and second generation. Let me talk a little bit about the mechanism, and then we'll flip over to that chart. So we talked about them antagonizing the muscarinic receptors. There are 5 types, major types of muscarinic receptors in the body. 2 of them we are concerned with, the M1s and the M3s. The M1s are in the brain. The M3s are in bladder, other smooth muscle. On that chart, I have put down their selectivity for M3 or M1. The first generations tend to be non-specific. So that's why you get so many side effects. So if you affect the brain, what kind of side effects are you going to get? So the drowsiness, change in cognition. So guess what list all these drugs are on? Beers. They're all on Beer's list. So, and who are the more likely people to be on these drugs? Older people. So you have to be careful. Use them carefully. M3, since they are smooth muscle, salivary gland, gut, what kind of side effects are going to come from stimulating or blocking M3? Constipation, dry mouth, vision, in the urination. So everything dries up. So if you'll kind of think of it that way, it will make sense. That way, if you have somebody who cannot tolerate one of the antimuscarinics, then you'll look at a chart like I've given you and say, okay, let's move one that is more specific for M3 versus one that is non-specific for M1 and M3. Dry mouth is the thing that causes most people to stop using them or to decrease adherence. So adherence is really poor with these drugs because the side effects are so high. With Oxybutynin, the incidence of dry mouth is 70%. Almost everybody will get it. All right. Flip over. I laid it out one way and then I didn't like it when I went through, so we're going to come back. So we've talked about mechanism of action. Go over to page 5. Let's talk about the products. So first generation, Oxybutynin, lots of dosage forms. So you have IR, immediate release. You have ER, extended release. There's a gel. There's a patch. There's a patch over the counter. So there's lots of ways to get the drug into the person. The cheapest one is the immediate release dosage form. It is probably the one that insurers are going to make you go after, use first. It's one of the least tolerated, but used on the lower end, it can be effective. But because most of these are much more expensive, so that one is less than $1 a day. A lot of the rest of them are $3+ a day. So they're a lot more expensive. So that's what insurance is probably going to force you down that road first. The others are Detrol, which is tolterodine, and then that fesoterodine is the active metabolite of Detrol. So those are the first generation. The second generation, trospium, which is Sanctura. I don't see it used very often. Kristen, you've seen it prescribed?
We get a lot of tolterodine and Oxybutynin.
Because that's what insurance will pay for. Vesicare is that sulfaphenacin. That's on if you watch. Do you see the commercials for drugs? I watch them all the time because I want to see how are you spinning this? Because it's direct to consumer advertising, which they haven't always been able to do. So I always want to listen through the ears of a patient. What are you hearing on TV when you show up in my office and say, I've seen this on TV? So Vesicare is one of them, and then Tobias is Darafenacin is Enablix, which is another one of the newer ones. So those are second generation. Consider second generation since they are more selective for M3. If you have patients who have cognitive impairment or you're worried about the effects on cognition, you might consider the second generation. There's no proof that they have less effect on development of dementia, but because of their selectivity, it might be worth looking at. All of them interact with 3A4s to some extent. I've highlighted the ones that are more problematic on the chart. The extended release products usually have the least side effects. And the ones that are transdermal usually have the least. So when I'm talking about the least, I'm usually talking more about constipation and dry mouth. Those are the two biggest ones. Okay. So look over on page 8 and 9. I'll kind of point some things out. First generations are on page 8. Page 9 is the second generation. So you've got the brand and the generic, and for Oxybutynin, I have put them down by the different dosage forms because they differ a little bit. In the next, I've given you their selectivity for M3 or M1. The other is I've given you some indication of what would be, how efficacy would be judged. So efficacy, so did you all talk about keeping voiding diaries? Okay, so with voiding diaries, you could use that as an indicator. Are they going to the bathroom less? Are they using fewer pads? Are they able to sleep through the night? How frequently are they having to get up through the night? Dosing, as you'll see, a lot of these have moved to once-a-day dosing. The patches are like twice a week. So adherence is terrible with these drugs. So as soon as you can move away from like 3 times a day to once a day, maybe a little bit better. The immediate release, though, are better when you have people who have desired effect at certain times of the day. They're quick onset and they don't last very long. So let's say somebody just needs coverage during X hours of the day. Then the immediate release are pretty good. The extended release are going to be all day, so you've got the potential for side effects all day, but their side effect likelihood is lower. So it is really a balance of what works well for them. So there's lots of different ways to go if people are if they're getting effect, but they're having side effects that are maybe interfering. Under the advantages and disadvantages, you'll see lots of information. So for oxybutynin, it's been around a long time. People know it. They've got experience with it. When I'm talking about people know it, I'm talking about providers. You'll see the high incidence of adverse effects, that 70% dry mouth. Not well tolerated in elderly people. They already have dry mouths, and they're already taking other anticholinergics. Be really careful with this class of drugs, because when you add them to older people, they're usually on other drugs that also have anticholinergic effects. Always think that. I can tell you most of the time when I'm looking at a drug profile, I can pick out 3 or 4 drugs on an older person's profile that are anticholinergic. It's just very common. The patch. There's a prescription patch and there's an over-the-counter patch. They differ significantly in cost, about $600 versus $30. But keep in mind that women can go out and buy that patch themselves. So another one to kind of keep in mind when you're talking to people. The gel is just if people don't like the patch or if they have reactions to the patch site application, a gel might be something to consider. Look at Detrol ER. It does have an approval to use for overactive bladder in men who are also taking alpha-adrenergic. I know you haven't talked about BPH yet, have you? So that's tomorrow. So the mainstay of treatment for BPH is going to be those alpha-adrenergic agents. So when you can mix these two, if you've got someone, and a lot of times that will help with their bladder symptoms, taking those drugs. But if they needed more and more effect, then you could add on one of these antimuscarinics. Look at the next page, page 2. These are the second generation. If you look at trospium, it is one of the least expensive, and it has the lowest risk of drug interactions. So, from my mind, those are things that stand out. If I've got a person who's on lots of 3A4 inhibitors, that's going to be a lot of your older people with cardiovascular drugs, statins. Okay? Then this is one of those that you might go, let's try this one first. Okay. Questions about those? Okay, come back to bottom of page 4, and we'll finish up this discussion and we'll take a break. So under therapeutic indication and monitoring, because of the side effects of these drugs, start low. Start with the lowest dose that's recommended and keep them on it for a couple of weeks. Then assess response. So things you're wanting to know is, how often are you going to the bathroom? How many trips are you making to the toilet every day? Don't be surprised that here is what did I put it down here? Oh, I got it a little bit. In terms of effect. Follow up at 4 to 6 weeks to assess response, but realize it can take up to 12 weeks to see full effect. So, number one, don't increase the dose too rapidly. The other is don't call it a failure too fast. Efficacy across all the formulations is about the same. Across the whole class of drugs, it's about the same. So what that you should take away from that is that I can move people to different things. Or it doesn't matter where I start, as long as I titrate up or I'm paying attention, then I'm okay. It isn't like I've chosen the least effective drug. Okay? Assess for adherence all the time because they're difficult to tolerate. Adverse effects, we've talked about those. Contraindications, be careful if people are already have urinary retention. Well, that would be terrible, is to have both of those. Or people who have severe GI motility. So this would be your diabetics. Could have lots of change in motility. And so putting them on these drugs could make it worse. They have gastroparesis, you could make it worse. Where did I put that? I went to... Okay, let's talk about Myrbetriq or Mirabegron. This is it's not an antimuscarinic, it's a beta-3 adrenergic agonist. It also has effects on the bladder. It is an alternative to the antimuscarinics. So if someone can't tolerate it, they're not getting effect, you can consider moving them to this drug. Much more expensive. The big side effects with it are increasing blood pressure, increasing heart rate. So they have cardiovascular effects, which would be with the beta agonist. Clinical effects, it's the same thing, decreasing the number of incontinent episodes, decreasing the number of times they have to urinate in a day. Avoided in people who are not well controlled blood pressure-wise. It inhibits 2D6. So there aren't that many drugs in 2D6, but metoprolol, some of the antidepressants, digoxin, your older folks may be on. So consider it in people who can't tolerate the antimuscarinics. There is some data that says combining them, this drug with the antimuscarinics in people who cannot get full effect from one drug or tolerate is using them together. Okay, page 7. Let's talk about it before we break. What I wanted to get down to, I've covered the first 4 bullets, but get down to the 5th bullet. Here's the clinical expectation. So this kind of puts it in perspective as what to expect. These drugs, this is why they're not first line. This is what we use them for before anything else. Doesn't it affect the problem? Doesn't cure the problem? For women who are taking them, they may go from 3 incontinent episodes a day to 1 or 2. They may reduce the trips to the bathroom from 11 to 9 to 10. Now for some people that may be significant enough for them to accept and tolerate the side effects of the drug. But I want you to know what effects to expect, and they're not major. That's why they're not first line. In terms of choosing them, all effective, you're going to go more on what the insurance will pay. That will probably get you first. And then other medical comorbidities that could be aggravated by an anticholinergic, their ability to tolerate it, side effect profile. And then think about cognitive impairment in your older patients who already are showing some cognitive decline. Okay, questions? Okay, that's urge incontinence. Most of the drugs are directed towards that. Okay, we'll take a break, we'll come back to stress incontinence when we pick up. So come back in about 6 or 7 after.
Yes.
Cut them off.
What?
Cut them off.
No, I'm just.